evening, everyone. Now we will have a discussion on subacute intestinal obstruction. It is a very interesting and a very vast topic, and we all have faced a lot of cases in our residency. I am Dr. Sailesh Gupta. I am an associate consultant in Department of Minimum Access Pediatric Surgery in Max Super Specialty Hospital, Patparganj. And today we have a panelist, Professor Dr. Vinod Malik. Sir has over 44 years in the field of general laparoscopic surgery experience. He did his MBBS from Kurukshetra University in 1976 and MS from PGIMR, Chandigarh in 1980. Sir practices at Sir Gangaram Hospital, and his expertise are in laparoscopic bariatric surgery, abdominal surgery, and next panelist we have Dr. Vasu Vashishtha. He is a consultant in Sir Gangaram Hospital. He is a NK Mehra Wadi in his post-graduation. He specializes in the lab upper GI and lab oncology. So now I'm going to start with the first scenario. 40-year-old male presented in casualty with severe abdominal pain with a complaint of repeated episode of bilious vomiting and non-passage of stool and flatters for 3 days. He has a past history of pulmonary tuberculosis, which was 4 years back, and he is a known case of diabetes mellitus and hypertension. On examination, pallor is present, pulse rate is 104 per minute, BP is 112/76, respiratory rate is 12 per minute. On per-abdominal examination, abdominal distension is present. There is a mild generalized tenderness, bowel sounds are absent. So this is a brief history and examination a patient has presented in a casualty. So based on brief history and examination, what will be the most probable cause or differential diagnosis in this case? I want to start with Dr. Malik, sir.
Can you go to the first slide, please?
Yes, yes, sir. Yes, sir.
So you mentioned that this patient has absent bowel sounds.
Yes, sir.
Right. So, and is there any, what's been the kind of patient's history between his pulmonary tuberculosis and the point at which he has presented to the casualty with pain abdomen and the current symptoms that you have described? Has he been having any symptoms, or this is the first time that he has had such symptoms?
Sir, he had diagnosis 4 years back. He took ATT for 9 months and was asymptomatic throughout the time. Just 3 days back, he had a pain and vomitings.
So I think this is the first episode of abdominal pain associated with distension and vomiting and absent bowel sound.
Yes, sir.
Right?
Yeah, right.
And he has had no previous abdominal symptoms, though he's a known case of pulmonary tuberculosis, has taken adequate treatment and has remained asymptomatic.
Right, sir.
Okay. So this is a brief sketch of this patient. And absent bowel sounds would sort of indicate that are we really dealing with an obstruction, or we are dealing with something else. So I would like you to really be a little more, elaborate about the tenderness. And I think you have said mild generalized tenderness. I would rather know whether this patient has any kind of rigidity, guarding, tenderness. I am kind of not really happy with the word mild generalized tenderness. Now, mild generalized tenderness can be associated with distended bowels, but by and large, the tenderness with, where we have guarding and rigidity, that would probably be very, very important in this patient. And I think even if they are not present, I think they should be described. In the context of this patient, can we go to the second slide? How I would like to initially, look at this patient, and would keep the possibility of this patient having probably some kind of a perforation, or maybe, this patient has come 3 days later, and therefore I think abdomen has become silent and initially started off with an obstruction. What could well be the cause of this obstruction? Well, this That's, I think, very, very important point in the in the examination of a patient suspected of bowel obstruction. First, whether this patient has an intestinal obstruction, whether it's a mechanical obstruction or a paralytic ileus, whether it is what could be the possible cause. Is it a complete obstruction or a partial obstruction, and is it a strangulating obstruction? So these are the points, which will remain always in our background in this patient. The first and foremost, I cannot very clearly say here that this is a patient of intestinal obstruction because abdomen is silent and the patient has tenderness. So in this situation, I would definitely like that I keep the possibility of a perforation right in the differential diagnosis, right? So that's how I will attempt this situation. Vasu,
So,
now we would like you, how would you look at the scenario that has been presented?
yes, sir. Sir, basically, in this patient, he had a history of tuberculosis, but that is 4 years in the past and has been treated completely. And because a 3-day history with absent bowel sounds, it indicates more towards not subacute intestinal obstruction per se, but it can be something else. We need to, and tenderness with tachycardia in this patient also denotes toward that. We need to mention about guarding or rigidity, as you already mentioned. And also, the absent bowel sounds, to say absent in a patient, we need to be very careful when using the word absent bowel sound, because the abdomen should be palpated at least 9 minutes in every quadrant in order to say that the bowel sounds are absent in that patient. Every region should be auscultated for 3 minutes. So that is a very peculiar term to use. And generalized tenderness in this patient with tachycardia is going more towards a perforation than acute intestinal obstruction.
So I think, as you very rightly mentioned, Vasu, that bowel sounds, and in the context of intestinal obstruction, we all know that initially there are exaggerated bowel sounds, and then subsequently, bowel sounds become infrequent. But by and large, in mechanical obstruction,